My presentation correlates of income and income inequality and oral cancer incidence and mortality in all and rich countries is based on my research as a postgraduate student at King's College London.
Sorry for the interruption. Whoever is participating in the poster sessions, please proceed to the dining hall and hang up your poster accordingly. If you don't go there, then we'll consider that you're not present. Thank you. Sorry for the interruption.
Now today we are all here because of globalization. Globalization has made possible trade, travel and exchange of knowledge, information and a lot more than that also. However, as far as the health concerns are concerned, unequal health is one of the manifestations of globalization. We know that in early years, communicable diseases spread through trade and travel, but because of globalization, even non-communicable diseases have become communicable. Public health is now a social issue, and in a lot of papers we heard that the causes of or the etiology of diseases as in terms of biological, environmental and other factors, but now it's a time to even look at the distal and proximal causes such as the socio-economic conditions and other factors. Globalization can be detrimental to population health, and as I mentioned, it has asymmetric manifestations because it has led to change in the lifestyles and behaviors of people world over. Before I go into my presentation, I would just like to mention a few terms that I will be using again and again. The first term is absolute poverty, which is an inability to meet basic human needs. There is another term, relative poverty, which indicates deprivation in relation to standards existing elsewhere in the society. Now, my study is based on an income inequality hypothesis, which is also known as relative income hypothesis. I'll be explaining that in a minute. This hypothesis was postulated by Wilkinson and Pickett in the year 2000, and it is well described in their book, The Spirit Level, in which they have correlated income and income inequality with an index known as Health and Social Index. So Wilkinson and Pickett have proved that a lot of health and social aspects such as the mean death age or the levels of certain diseases and even the social aspects such as crime rate, homicidal tendencies, suicidal tendencies or teenage pregnancies, all those aspects were related to income inequality in when you study them ecologically. So the hypothesis sustains that up to a certain level of absolute income, health improves with increase in absolute income. However, beyond a certain tipping point, absolute income doesn't improve health, and relative income or the income disparity or the income distribution is a primary determinant of health. Now, this kind of an ecological association you find in large geographic areas such as countries or states within countries. Now, why does this happen? There are mechanisms because of which income disparities or improper income distributions can lead to a status of anxiety within a society through socio-behavioral mechanisms. And because of these mechanisms, the stresses are the main reasons for a variety of problems. The good news is this is a reversible phenomenon. So if the income inequality reduces, then that can improve health and social factors in a society. Now, this is just one example. That is the life expectancy as studied by Wilkinson and Pickett. We can see here that beyond a certain tipping point, maybe at around 25,000 of gross national income, we can see that the life expectancy doesn't improve. And if we study a group of these rich countries, then we come to know that income inequality is a primary determinant. One example is in a city of Glasgow, the life expectancy of a rich person is more than 85 years, whereas that of a poor man is just 55 years. So it can be as much as that. Now, how income inequality can affect health? Because of the compositional effect. So if poor people are living together, then probably the society will have certain problems related to poverty. It can also be a contextual effect. That means if rich people and poor people are living together, but the income distribution is varied, or rather it is there are extremes of richness and extremes of poverty, then the crime rate in the society would be high, and that will affect both rich and poor people equally. So this is a contextual effect, an example of that. Now, how it affects health, because social processes, policies are determined by the composition of the society, then there can be damaging interpersonal relationships if there is income disparity because of competitiveness, because of lack of awareness, and there can be some stress, as I mentioned, also known as status anxiety, that can be a reason for improper health and social aspects. Now, why we studied the association of income inequality and oral cancer? A lot of non-communicable diseases and the rise of them has been linked to these economic and socio-economic factors, and we wanted to study this association of oral cancer because oral cancer is, as mentioned by many other speakers, it accounts for one of the top 10 cancers of human beings, and the risk factors associated with oral cancer can be related to the implications of income inequality through the psycho-socio-behavioral mechanisms. We first reviewed the available literature, multi-level studies on income inequality and oral health, ecological studies on income inequality and oral health, and studies on income inequality and oral cancer. However, we couldn't find much evidence linking the association of income or income inequality and oral cancer. Now, I have no time to go through the studies, but we can see that income inequality in terms of Gini index has been linked with self-rated health, poor dental status, caries and gingivitis, tooth loss, also DMFT, that means caries again, then periodontitis, again DMFT. Yes, this was a study, but it was not a multi-level study. It was just a study within a small population, as we can see here. And this was study correlating the socioeconomic status, and it mentioned that oral cancer along with dental caries and periodontal diseases are socioeconomic status of people. So the aim of our study was to assess the correlates of income and income inequality with oral cancer incidence and mortality in all countries, and also to test the Wilkinson and Pickett hypothesis, and we applied the same thing to the group of rich countries. Now, the association of income and oral cancer incidence, income and oral cancer mortality, income inequality with oral cancer incidence, and income inequality with oral cancer mortality. These were the 4 objectives. It was an ecological study. We did a secondary data analysis. The importance of these studies is to gather such a big amount of primary level data is almost impossible. They are prone to ecological fallacy, but however, they give us very useful and important information on the basis of which multi-level studies can be conducted. How we got hold of these income measures? Now, World Bank provides data, and we took the absolute income measure from the World Bank records. We chose Gini index as the income inequality measure. It is one of the most commonly used measures for the income disparity, and I will briefly describe what a Gini index is. The distance between this Lorenz curve and the line of equality is the Gini. That means if the straight line means that the income is very well perfectly distributed, and if it is say 80% or something like that, then it is very unequal. Now, we chose age standardized rates as provided by the Global Cancer Directory or GloboCan. And the age standardization in the rates of oral cancer is important because in different populations it differs with respect to age. And GloboCan rates are the incidence and mortality, as we know, the number of new cases reported. They are summarized by the GloboCan, and 2008 data was available, so we chose that. The cancers of lip and oral cavity are grouped together by GloboCan as the oral cancers. We wanted complete data on all countries, however, some data were not available, and these 3 countries had to be excluded. In a group of rich countries, we chose the top 50 rich countries in the world. However, a lot of countries had to be eliminated because the populations were smaller than 2 million, and the tax haven countries have been removed out of this group. The same group has been studied by a lot of investigators. Unfortunately, we couldn't get proper information about Netherlands, and so we had the data related to oral cancer. So we had to exclude that from our study. This is how our data set looked like. We used SPSS 18 version, and the distribution of variables was non-normal, so we had to go in for a Spearman correlation analysis. We couldn't do Pearson analysis. Now these are the graphs. We can see that this is a very mild to moderate association of the incidence of oral cancer with the income, gross national income. Here there is no significant association between the income and oral cancer mortality. A little bit of, again, mild inverse relation between the Gini index and the oral cancer incidence in all countries. Again, mild to moderate inverse association of mortality to Gini index in the group of all countries. Now, in the group of rich countries, we could not find any association. As we can see here, the p-value is much more than 0.05. Same thing, we could not find any association of oral cancer related mortality with the gross national income in the group of rich countries, and neither we could find any relation in the group of rich countries of Gini index with the incidence and mortality. So basically we couldn't find much relation doing a correlation analysis between the income and income inequality parameters with that of oral cancer incidence and mortality in all and rich countries. We carried out a bit of additional analysis because we thought that annual cigarette consumption is the primary risk factor for the oral cancer data. So we found out the annual cigarette consumption in all the countries, and we came to know that it was related to income, but it was inversely related to the Gini index or the income inequality. That means the hypothesis that we wanted to test didn't find enough support through our study. And what could be the possible reasons for that? We know that the information on oral cancer incidence and mortality is available to us through Globocan, which is based on the cancer registries and death registries, and in the developing countries probably the information that is updated is not so accurate. Then there is an effect of time lag. We chose the data related to income for the period 1998 to 2000, and the cancer data in the year 2008. So there was about 8 to 10 years of time lag. Whether that is sufficient to observe the effects of income and income inequality, that is not known to us as of now. Then there have been a lot of biological factors differently responsible in different populations in the world for oral cancers, and also the oral cancers as described by Globocan include certain cancers such as the lip cancers, which have entirely different etiological factors. So these could be the possible reasons for the lack of support of income inequality hypothesis. Of course, this being an ecological study, we cannot see what is happening at an individual level. We had to collect data from different sources. The group of rich countries, as I mentioned, there wasn't data available for Netherlands, although it is less likely that the inclusion of data on Netherlands would have drastically changed our results. And we couldn't consider other factors such as education or the human development index or certain more composite indices. We chose very simple income and income inequality in terms of Gini for the correlation purpose. So I would conclude that oral cancer incidence increased as income in terms of national income per capita increased in all countries but not in rich countries. And there was no impact of income measured as gross national income per capita on oral cancer mortality in all or rich countries. The greater income inequality measured as the Gini index was related to lower oral cancer incidence in all countries, but there was not such a trend observed in the rich countries. And oral cancer mortality decreased with greater income inequality in all countries, but not among rich countries. So that means it provided little support for the income inequality hypothesis in relation to oral cancer incidence and mortality. I would recommend that further ecological studies with longer time lags and in different populations within country state comparisons and multi-level studies are recommended, and we should also look into the net effect of various determinants such as income inequality, education, employment, ethnicity, cultural factors and biological factors, because the disease is related to a multifactorial etiology. Thank you so much.
We thank Dr. Ashwin. Yes, his certificate.